Hi folks, welcome to my channel, The Average Dermadoc. Let's begin the show. Dexamethasone Cyclophosphamide Pulse. Administration of large doses, suprapharmacological doses, huge dosages more than the therapeutic dose at a time, intermittently and giving a gap. In this manner, if you give, this is because to enhance the therapeutic efficacy more than the therapeutic dosages you are giving in large dosages to increase the therapeutic efficacy, and we are giving a gap period in between the high dosages, that is we are giving pulses in intermittent manner to reduce side effects of giving daily. Where and all this dexamethasone cyclophosphamide pulse is used in Pemphigus vulgaris, mainly Pemphigus foliaceus, pyoderma gangrenosum, systemic sclerosis, SLE, mainly bullous SLE, sclerodema, sarcoidosis, dermatomyositis, Darier's Hailey, disseminated porokeratosis and prurigo nodularis, generalized murphia. These are all the conditions where DCP pulse is used. Next, how many pulses, how many days we have to give? We have to give in. First we will see about what is a pulse. One pulse will be for 3 days IV. On day 1 we will give Dexa 100 mg dexamethasone in 5% dextrose, not normal saline, in 5% dextrose in 500 ml, slow infusion over a period of 3 hours. On day 1, day 2, day 3, in all the 3 days Dexa 100 mg we will give in 5% dextrose. Why not in NS? Side effect of steroids is hypernatremia and hypokalemia. Here already in NS sodium will be there, so we will avoid. Here we are giving dextrose. Day 2, both Dexa and 500 mg high dosage suprapharmacological dose of cyclophosphamide. In the same solution we will inject and give over a period of 3 hours. Coming to day 3, only Dexa 100 mg. On day 2, remember like this, second day 2 drugs, both Dexa and cyclophosphamide. On day 1 and day 3, only Dexa. 50 mg cyclophosphamide oral daily in between the pulses or non-pulse days. I already told you one pulse will be given for 3 days. Which days? On day 1, day 2, day 3 of every month. In between 2 months, first 3 days, there will be a gap period. This gap is nothing but non-pulse days are in between the pulses. Low dosage of cyclophosphamide we will give 50 mg. How many pulses, how many days we have to give? We have to give in 4 phases. In phase 1, until the lesions resolve, we will be giving, but for a period of maximum 12 months. We will see for 12 months lesions resolving or not. If lesions resolve, we will go for phase 2. It will continue for a period of 9 months. In both phase 1 and phase 2, we will give both dexamethasone cyclophosphamide pulse and oral cyclophosphamide in between the pulses. Next we will go to phase 3. Here we will withdraw Dexa and we will continue only oral cyclophosphamide for a period of 9 months. Next, this oral cyclophosphamide also will withdraw after 9 months and will enter phase 4 monitoring phase, where patient is monitored yearly once for a period of 10 years. Phase 4. During the pulse therapy, we have to monitor during that infusion blood sugars and blood pressure, LFT, RFT, electrolytes. I already told you steroids will cause hypernatremia and hypokalemia, and urine routine. Mainly cyclophosphamide will affect the bladder, causing hemorrhagic cystitis. ECG and cardiac assessment in elderly. Why? if they develop arrhythmia due to hypokalemia or any other electrolyte imbalance, we have to immediately stop infusion, because both cyclophosphamide and steroids, when combined, it will lead to fluid retention. Dexamethasone azathioprine pulse. Wherever cyclophosphamide is contraindicated, we will use azathioprine 50 mg as an alternative to cyclophosphamide. In between pulses, we will give oral 50 mg azathioprine. In pulse, we will give only Dexa, day 1, day 2, day 3, 100 mg. In between pulses, 50 mg azathioprine. Why? Because cyclophosphamide is contraindicated in pregnancy, because it is a teratogen. Lactation, it has so many side effects. We don't want to transfer the side effects to baby, because this drug will be excreted to breast milk. What are those side effects? It is a carcinogen. It will cause bone marrow suppression, hepatotoxic, cardiotoxic, nephrotoxic. It is gonadotoxic as well. So unmarried, both the genders, male and female, it's a relative contraindication. Uncontrolled hypertension, along with steroids, if you give cyclophosphamide, it will cause even more fluid retention. Dexamethasone methotrexate pulse. Why we will give this? When phase 1 with both Dexa and cyclophosphamide pulse, Dexa and azathioprine pulse, it is extending more than 12 months. Lesions are not resolving. We will wait for a period of maximum 12 months by giving pulses. If it is not reducing, lesions are not resolving, then we will go for a third alternative, methotrexate 7.5 mg weekly once in 3 divided doses. 2.5 mg every 12th hourly, in between the pulses, weekly once. Coming to adverse effects of DCP, cyclophosphamide, I already told you, it is gonadotoxic. So it will cause azoospermia or oligospermia in males, amenorrhea, ovarian failure in females. So we'll give as an alternative, A for azathioprine in place of cyclophosphamide 50 mg. Hemorrhagic cystitis. What is the treatment for this? IV mesna and hydration. We have to hydrate well the patient to clear the cyclophosphamide from the bladder to prevent further damage while giving the pulse. Diffuse hyperpigmentation, hair loss, hepatotoxic and cardiotoxic. Coming to dexamethasone, already we know side effects of steroids: acne, gastritis, diabetes mellitus, hypertension, exogenous Cushing's and cataract. So we have to monitor for cataract. Eye examination, we have to examine bones through x-rays and bone mineral density monitoring. Because of osteoporosis, avascular necrosis, spontaneous rupture of Achilles tendon also will occur with Dexa. Increase the risk of opportunistic infections while on high dose of steroids. Remember my channel name, The Average Derma Doc. Don't fail to subscribe and share my channel. Thank you. Link for the PDF to read will be given in the description. Click the link and download and read. Hasta la vista. Das vidania.